For those of you who don't know me, I'm Jeanette Williams, and I'm Interim Head of Staff Experience. And this session is hosted by our Looking After Our People team, because we all have different functions to bring these sessions on. And we have a fantastic session for you, and I'll hand over to Carol and Dr. Giles Allen now. Carol?
Thank you. Thanks, Jeanette. Thanks a lot. So again, for those who don't know me, my name is Karol Kuchera. I've got a dual role. I job share with Jeanette as Head of Staff Wellbeing and Experience, and also I work as the EDI Regional Program Manager for NHS ENI East Region. So on from the presentation on trauma and post-traumatic stress we had a couple of weeks ago, I'm very excited to introduce to you Dr. Giles Allen. He's a psychiatrist, EMDR therapist, and a psychodynamic psychotherapist. He will talk to you about the trauma-informed practice. That is the subject for today. Giles used to work for addiction services, where he developed interest in trauma and trauma-informed practice. I personally had the privilege to work with Giles through Health Education England, where we delivered training on trauma-informed practice for HR directors as part of the diversity and inclusion framework. So I'm really, really happy that Giles can be with us today, and I'm sure you will learn a lot from this presentation. So Giles, back to you. I will do the screen share. Need the next slide, just please say next slide.
Okay, great. Thank you so much. Can people hear me okay?
Yes.
Great. So
yes.
Thank you, Carol, for that introduction. Thank you, Jeanette. Good to be here today, everybody, for this talk that I'm going to give on trauma-informed practice, which follows on from what Carol was speaking to recently about the sort of neurobiology of trauma and post-traumatic stress. So trauma-informed practice is something that's become increasingly important within healthcare services. Carol and I were doing some work with Health Education England in the context of diversity and inclusion, working with BAME staff and issues around trauma and discrimination. But obviously that the big broader issue around trauma and the impact on healthcare has really been brought into focus by the pandemic. And today I'd like to speak to you about trauma-informed practice in the context of the pandemic and how we can think about how we can support our staff and improve well-being. So just in a nutshell, trauma-informed practice is really about recognizing how common trauma is, whether in our staff, our colleagues, or in our patient group. The fact that trauma underlies a huge range of mental health problems, whether that's depression, anxiety, a psychotic illness, personality disorder, post-traumatic stress disorder. And if we can recognize the trauma, we're better able to support people who've been traumatized, and we're better able to reduce the risk of people being re-traumatized in the future. And that should have a beneficial impact on staff and patient well-being. Next slide, please, Carol. So really just a brief précis of trauma, some definitions and types of trauma. So really a very succinct definition of trauma is to say that it is an event that is highly stressful and overwhelming. And I think the important word there is overwhelming, so that something happens that overwhelms our normal ability to cope. And these traumas can result in feelings such as anxiety, guilt, helplessness, and these feelings may still be felt long after the trauma has ended. And that's because traumas and the trauma memories get encoded in the limbic system in the emotional brain, so they don't get stored as normal narrative memories, and they have the ability to kind of replay over a long period of time, triggered by similar events, situations, or recounting the experience repeatedly. And obviously in the context of the pandemic, this repeated low-level trauma is something that I think we're all familiar with, and certainly our patients are too. So broadly distinguished into two different categories. Type 1, they're highly distressing, usually unforeseen one-off events, for example, an accident, a mugging, a death of a loved one, or injury or disability. And type 2 traumas are the more prolonged and complex situations that accumulate and evolve over time, most commonly interpersonal traumas, for example, physical, sexual, emotional abuse, which may, as I say, occur over a period of time, domestic violence, torture and bullying. And generally these sorts of traumas cause the more severe and longer term impacts. Next slide, please, Carol. So today, let's think about trauma in the context of COVID, because obviously we're working in this extremely challenging environment with our staff and patients both, faced with the same difficulties in terms of the impacts of the pandemic and the lockdown. And we're aware that there's an increase in symptoms of anxiety and depression in the community, both in children and in adult populations. There's a recently published study by a chap called Greenberg that looks at 703 staff, I think it's over 700 staff working in intensive care, looking at the impacts on their mental health. And it was discovered that nearly 710, out of the 710, about 45% of these people met the criteria for either severe anxiety, severe depression, or symptoms of post-traumatic stress, problems with problem drinking. And it was noted incredibly that people with the post-traumatic stress disorder, that those levels were twice as high as people with combat stress. So they're really extraordinary circumstances that people are working in. So, and we can imagine that these increases in PTSD, anxiety, depression are also being replicated in all kinds of frontline environments, whether that's accident emergency, inpatient settings. So a really, really big burden on our staff, which is leading to more staff sickness, and that's leading to further resource shortages, and the staff remaining at work having to cope with more bigger caseloads and increased stress themselves. Inpatient environments are becoming more pressured as staff are having to deal with COVID outbreaks, whilst also having to meet the needs of very unwell patients. And I run a reflective practice group called a Balint group for GP and psychiatric trainees. And you can tell how much stress the people working on the wards are under. You may have somebody who's acutely psychotic, who may need to be restrained and may end up in seclusion, but at the same time may have tested positive for COVID. So you've got to manage the needs of protecting other patients and staff from COVID. The PPE may or may not be up to scratch. Hopefully these days it is up to scratch. And you've got paranoid patients also worrying about the impacts of COVID. And it's an extremely distressing environment to work in. And in the community, you have increased anxiety in staff through the reduction in face-to-face contact, and it's impacting on job satisfaction and the ability to accurately assess patients' mental states and associated risks. I mean, certainly my experience of working in the community, working from home, is that the majority of my patients don't really want to do video calls. A lot of them don't have the technology set up, or they feel it's too intrusive to have a doctor or a colleague appearing on their screen in their home. And that means you're just left with phone calls with lots of people. And it's so much harder to really gauge where people are at with just the voice. You're missing out on lots of perceptual information that you normally have access to if you were meeting with people face to face. So that not only does that make our patients and service users feel less contained and less emotionally reached, it makes us feel more anxious because we're really not sure exactly what's going on. And that, of course, has an impact on us day to day as we try to hold a resilient position and an optimistic position for our clients. Next slide, please, Carol. Of course, not only does COVID have a massive impact on people's mental health, there's a huge impact on physical health and an increase in the inequalities between those with good and poorer health. Some data has shown that those on low wages are 7 times as likely as high earners to have worked in a sector that's been shut down. Management of long-term health conditions has been put on hold to deal with the COVID crisis. We've all heard stories of during the first lockdown that A&Es at times were quite empty because people with, suffering with heart attacks and angina and all kinds of acute physical health problems were just not presenting to A&E because 1, they didn't want to catch COVID, and 2, they were doing what they thought was their civic duty to stay at home and avoid the risk of spreading disease. Also, we know elective surgeries have been cancelled, and routine treatment of diabetes and cardiac conditions has taken a second place to the massive impact of COVID on primary and secondary health. Those on lower incomes are more likely to have to continue travelling to work, which may mean public transport, which may mean exposure to COVID. Less than 1 in 10 of the lower half of earners say that they just haven't had the option to work from home at all during the lockdown, compared with half of the highest earners. So again, a massive inequality there. And as we know, poverty and insecure work have well-established negative impacts on people's health through the effects of deprivation and social isolation. Moreover, we think about the massive health burden on our children. I mean, those of us who have children are trying to work from home, often full-time, with our kids trying to do homeschooling, having a big impact on their educational prospects. from more disadvantaged families, there may only be one screen or no screens in the home that people can access the home learning from. And then, of course, we're worried about those kids who were safer at school, who may be more at risk of some kind of emotional harm in the homestead, and likewise, increased risk of domestic violence, alcohol and substance misuse within people in disadvantaged environments who are stuck at home, often struggling for work. Next slide, please, Carol. Again, ongoing with the health inequalities, so people facing the greatest deprivation are experiencing a high risk of exposure to COVID-19 for some of the reasons I've just mentioned. And they also, existing poor health puts them at risk of more severe outcomes if they contract the virus. And this is unfortunately exposing the structural disadvantage and discrimination faced by parts of the Black, Asian and minority ethnic communities. I mean, we're aware that there's a lower uptake of vaccine among BAME work populations, and it just adds to this incredible sense of people not getting the help that they need, and the fact that this virus is really affecting people's health and just accentuating these inequalities. And of course, the measures we have to control the spread of the virus and to save lives are exacting a heavier social and economic price on those already experiencing inequality. And these measures, the lockdown, social distancing, cancellations to routine care, lack of travel opportunities, are all having wide-ranging implications for income, job security and social contact. So it's really a perfect storm of problems that we're all facing. Next slide, please. Just a little bit about the impact on the BAME population. I mean, this is a workforce who are already feeling discriminated against. So the impact of COVID is increasing that even further. BAME and disabled people are often re-traumatized repeatedly simply through the process of trying to get help. And this has contributed to underreporting of problems, particularly around grievance and discrimination, increased anxiety in this population. There's this concept of the stereotype threat that leads to impaired performance. It's the idea that people from ethnic minorities feel that they conform to these negative social and cultural stereotypes, and that has an impact on their employee engagement, an impact on their performance. But of course, issues around underreporting of trauma and difficulties at work are not just in the BAME workforce. It can happen with all of us, really, particularly at this time where people may be feeling very isolated. It may be very difficult for our managers or colleagues to recognize that we're struggling because you've just got little faces on screens or just a voice. You're not having those informal discussions in a kitchen or in a team meeting where you get a sense that somebody might be struggling. It's just that much harder to pick up on people's difficulties. And also working in healthcare, at least we've got a job. People may feel really guilty about the idea of complaining when they're thinking of all the people who've lost their work, and at least I've got a job even though I'm feeling overwhelmed and really struggling. So all of these can really impact on how we actually recognize difficulties and how we help people when they do present with these difficulties. Next slide, please, Carol. So in terms of mental health, I mean, we're all aware of post-traumatic stress disorder. Again, it's when people are traumatized. I mean, to actually have a diagnosis of PTSD, you have to meet certain kind of thresholds of various issues, but we hear about nightmares, people either being hyper-aroused or hypo-aroused. Some people may sort of shut down and go into a freeze state where they dissociate and can't think. Other people may be feeling much more agitated and aroused, and that may manifest as anger, irritability, difficulty concentrating, poor sleep. These flashbacks where people feel the event is happening again in the now, intrusive thoughts. It's really a very unpleasant condition and leads to all kinds of other issues in the context of low mood, sleep disorder, problems with relationships, etc. Next slide. So let's think about the impact of trauma in the workplace. I mean, from the perspective of the individual, people may feel ashamed that they're struggling, that they feel whatever trauma they may have experienced in their life historically may have been reactivated by the traumas of working in a COVID environment. We certainly know that the impact of working directly with people who are suffering with COVID causes an increase in anxiety and depression in our workforce from some of the studies that are being done. There's anxiety about catching COVID, the anxiety about bringing COVID back into the home from work, this sense of contamination, and just this sense of an unseen threat. It can bring up feelings of shame, feelings of not being good enough, of fear, of loss of confidence. Obviously, the sense of isolation is around us all the time. We're all sat in our little silos on screens, on the phones, walking with masks, stepping into the street to avoid people on the pavement. It's just such an unusual environment that we've had to sort of become used to. And of course, that can lead to the risk of repeated trauma. But day after day, people are exposed to these very challenging circumstances, and yet we're having to develop resilience somehow. And, you know, and what does that word really mean? I mean, how can we be resilient when we don't have the resources and we don't have the means of communicating our distress and feeling that we can be heard? And of course, all of this can lead to a risk of drop in performance. You know, people understandably are tired, they're worried about going off sick. And even when they're at work, they're too anxious to do the job as well as they might like to. And what about the employer? I mean, of course, if an employer isn't properly looking after its staff, you've got increased sickness, you've got people suffering all kinds of difficulties there, whether they're coming to work or not, their performance may be suffering. And if you've got you know, if it's impacting on the well-being of staff, it may affect the reputation of an employer. You know, an employer wants to feel that its workforce trusts its judgment, trusts its culture. We may worry about vulnerable working environment. For example, is PPE adequate? Are we able to socially distance safely at work? And how do we manage that in inpatient settings where there's a very intense environment with lots of people in close proximity? We may worry about breach of regulations, for example, again, around PPE, and particularly around, you know, grievance policy, things being followed in a robust, transparent manner, and how does that impact on the culture of the organisation? And of course, how does that impact on talent retention, on recruitment and retaining good staff who continue to make the employer a good place to work and somewhere that wants to bring more staff on board? It's going to have an impact on individual behaviour in lots of ways, really. People might start to withdraw, they give up on projects and people. You know, we're trying to do our research, we have our admin, how do we fit it all in? We find ourselves working early in the morning or late at night because we, you know, and that impacts on our weekends, it impacts on our time with our families. But sometimes we just feel there's just not enough time in the day for us to get everything done. We worry things are never going to change. We're constantly trying to sell a story of optimism to our patients. Oh, you know, the vaccine's coming, the numbers are going down, but we're still in this cloud of uncertainty. You know, what's going to happen, and how do we maintain that sense of optimism and sense of psychological robustness in order to make our patients feel that they can remain hopeful? We have to try not to shut down and become increasingly isolated in our little silos. We might become cynical. You know, the sense that we feel worn down emotionally, we can get angry a lot, we feel exhausted, burnt out, we become sick, we may miss work for all sorts of reasons, and sadness may lead to depression, anxiety, and needing to access support from our GP, which may be very difficult to get, given how overwhelmed GPs might feel. And we can sit for an hour on the telephone just trying to book an appointment. So all of these things, again, can have a real impact on us as individuals. Next slide. So in terms of, you know, that may be the day-to-day experience, but over a long period of time, you know, having a history of trauma and being in an environment where you are at risk of being traumatized on an ongoing basis, people may have problems with keeping and making relationships. They struggle to find a way of forming good bonds with colleagues at work. You may struggle to maintain relationships with friends and family. You may find it difficult to maintain work and be in and out of work or in agency situations. It may be more difficult to focus on our career in the long term because we're feeling so overwhelmed and preoccupied with the sort of day-to-day managing of our life and trying to find a way to keep our energy up and to keep optimistic and resilient, that we can't really see the bigger picture. It's very, very difficult to think more strategically. And that, of course, will have an impact on the way services are delivered as well, because the people running the services are going to also struggle to see the bigger picture. And it may be difficult to control our feelings or behaviours. This is something a patient said, it's scary. One moment I'm really happy, and then the next I'm crying for absolutely no reason or having a go at people. People think I'm just being moody for the sake of it. And we can all probably relate to that at some level, just this sense that it's very hard to have this consistent sense of well-being, that there's this feeling that we're all being, you know, it's a really very, very challenging environment. Next slide. So really we need to now think about the benefits of trauma-informed practice. And these are considered sort of pillars of this idea of trauma-informed care, trauma-informed practice, collaboration, empowerment, safety, choice, and trust. And they're really all interrelated and quite a pragmatic approach, really. But I suppose that, you know, the purpose of doing training sessions like this is it's about collaboration. We're improving awareness of the impacts of trauma across the workforce. Empowerment, you know, how can we facilitate staff access to mental health support, whether that's through apps, whether that's through improved access to virtual spaces, whether that's online or video support, face-to-face where appropriate, and how can we reduce shame in asking for help, improving education so people realise that these are really common difficulties people suffer with, and that may reduce the shame and make people feel that it's okay to ask for help and it's okay to share their stories in order for other people to know how many other people are in the similar position. How can we improve psychological safety for staff and service users? We need to provide safe spaces, whether real or virtual, where support can be easily accessed. And we need to give choice to both staff and service users so they have more self-agency and they can choose where and how they access support and possibly use independent support where appropriate. And all of this, if properly implemented, can lead to better trust in organisations, and hopefully we can improve our accountability so that there are good ways of auditing the work we do in this area, and so that people can draw on that and we can show that things are being done in a sensible way. Next slide, please. Again, this is really about embedding trauma-informed practice for our employees. We need to try to reduce isolation. That's why it's great that you guys are having these meetings, frequently with a period for mindfulness, just so that people get a sense to come together and this becomes a safe space where people can check in an informal way, then have a piece of learning, and then again have a bit of time afterwards to debrief and just have that human-to-human contact, which is so much harder in the middle of a pandemic. So how can we improve our networks? How can we improve the technology so that people feel less isolated? Again, improving choice. Do people have access to internal or external support if appropriate, not just via your line manager? And that may particularly be an issue with BAME staff worrying about discrimination within their own team and how they can reach out for more appropriate support from elsewhere. We've got to think about leadership and how our leaders can be trained properly, how they can be accountable, they can be committed, caring and informed, and know about this culture of continuous improvement. So leaders learn how to spot the signs of trauma, so that somebody who's running a team meeting gives people the space to feel if they're going to be triggered, that it's okay to step out and just have a breath and do a little bit of mindful breathing, and then to come back into a space, or just to find ways of just noticing if people seem that they're just not themselves. How can we improve that way of recognizing difficulties so that communication between employer and employee can improve and that teams can run more effectively? And this, of course, all depends on good training, regular CPD for anyone requesting, particular training around trauma-informed practice, discrimination, inclusion, etc. And, of course, ways to audit all these measures, good governance, good robust governance in place, measures, progress checking, feedback forms, evaluation of trauma-informed practice, so that people can feedback to us so that we can deliver better training, and so that the training can be shared across teams and people can deliver it and it can be used in lots of different settings. Thanks, Carol. And then I think there's one final slide. And then again, this is all just really bringing back these important aspects of trauma-informed practice. I've got here 9 ingredients. Probably could be pared down a little more, or it could be elaborated on. But effectively, again, it's leading and communicating, co-production of practice. So that's involving service users and colleagues from different areas, so that this, the training is planned and lots of different people are involved, so that that it can all be thought about in a really equitable way. You need to train all staff, create a safe environment. That's whether that's a physical space or a virtual space. You need to try to prevent secondary trauma, which is what we've been talking about throughout this discussion. And if people have good training, you're building an informed workforce. So this idea of trauma-informed care, trauma-informed practice, is a kind of lens that people can see everything through, which enables us to better spot it and to work with it. We need to screen properly for trauma, and we need to use trauma-specific treatments, whether that's a formal intervention like EMDR, trauma-focused CBT, or just using simple mindfulness and stabilization techniques, which I expect Carol spoke to you about in his last presentation, and hopefully some of us will be aware through our daily mindfulness practice, or just the idea of helping people stay in their bodies, and just ways of helping people feel less triggered and more present. And of course, engaging with our partners, improving communication and sharing stories from one another, so that we can deliver helpful training that feels useful and shares a consistent message of compassion and hope across lots of different services. So that's the end of my presentation. So thank you for listening, and I'd be very welcome for any comments or questions. I've got a bit more time now, so thanks very much.
Brilliant. Thank you so much, Giles. That was really very, very informative. The two things I'm taking from it is it really stood out for me when you said discrimination is trauma, and I think that is something that, you know, it is helpful to have kind of at the back of your mind that whenever you're coming across something in the workplace, or something when something just doesn't work properly, you know, perhaps to bring that sentence back into one's mind. And then, of course, the 9 ingredients for trauma-informed practice. So if you're happy to, we will open this to Q&A. I don't know if there's anything, or Jeanette, coming from the chat box as well.
Yes, so if you do have any questions, you can raise your hand or put your questions in the chat box, or if it's a comment, we will pick that up as well. So we have some time. Penny, you have a question? Go for it.
Yes, thank you so much, Dr. Giles. That was really very informative. Can I ask, if we experience trauma or meet people who have experienced trauma, will they also be experiencing moral injury as a result of that trauma?
That's a very good question. I think it would depend entirely on the individual and the nature of the trauma. I mean, if it was a trauma that was in the context of somebody's ethnicity and it felt like it was related to discrimination, or it may be to do with their gender or some characteristic where people are feeling traumatized because of discrimination in that area, absolutely, that could feel like a moral trauma. But I think it's going to vary from situation to situation. I mean, I think one of the awful, COVID in itself, it across all boundaries, everybody is being traumatized by COVID. But again, unfortunately, it's highlighting the inequalities even more. So people from disadvantaged backgrounds, and they could be lots of different reasons for that, are feeling even more, potentially traumatized by the effects of COVID because of the impacts on their health and access to resources beforehand.
Thank you.
Thank you so much.
Okay, so we have some other hands. I'm just looking. Adele, you have a question? You would like to come in?
Thank you, Jeanette. Yes, so a question for Giles. Thanks for the presentation, really useful and informative. I'm hearing more and more about this kind of practice and approach, and I'm just wondering if you have any information on, if you were looking at implement this in an area or areas, is there some guidance or evidence around, the best way to approach this? Would it be sensible to pilot it in one area? Is it something that, you do organisation wide, just to get a sense of, how one would go about, looking at this in terms of, part of their overall wellbeing approach at this time?
Thanks, Adele. Very useful question, very important. I mean, I think the answer is yes. There is a good evidence base that's helped the whole kind of trauma-informed practice and trauma-informed care paradigm evolve. So this idea about, trust, collaboration, choice, reducing isolation, they're all based on evidence. And, there are certain trusts across the country who are kind of, pioneering a trauma-informed practice as part of their kind of paradigm of rolling out services. So I think there are models out there. We are trying to develop training, and Carol and I in time may be able to sort of, offer more advice and consultancy. And I think perhaps, Carol and I can kind of come up with something that we could send in terms of some evidence to point you towards. But certainly there are lots of examples of people implementing some of these principles in their workforces. I mean, obviously it will need to be bespoke depending on people's environments and the particular demographics of different trusts, exactly how that works. But absolutely there's lots of evidence that it's reducing sickness, increasing morale, reducing grievance, and bringing I suppose a more optimistic workforce. I think the challenge now is how resilient these, or how flexible these methods are given the pandemic. And I suspect some of the stuff will need to be revisited and implemented in different ways, because we're faced with having to deliver training in virtual spaces. We're having to support people, assess people, treat people in virtual spaces, and that brings a whole other set of challenges. So I think some of it will need to be reimagined for the age of the pandemic. And I think we're going to see a very long tail of kind of trauma-related morbidities emerging in the years ahead, which will mean that it'll be an ongoing challenge how best to deliver trauma-informed practice. But the short answer to your question is yes, we know it works, and it can be implemented through, you know, some very sort of straightforward ways of looking at the way healthcare is delivered and staff are supported.
Thank you. And I'll just bring Leslie Ann in here. Leslie Ann, you have a query?
Yes, thank you. Really, really interesting presentation. And I wanted to pick up on I think for us at the moment, there are certain areas in an acute hospital you expect staff to see trauma, to be exposed to trauma, and those staff are kind of not prepared for it, but I'm guessing their training has given them some sort of resilience to that. What we're seeing now with the amount of extremely acute mental health patients that are coming into us are some really, really extreme instances of trauma that staff are being exposed to in areas you wouldn't normally associate this with. And picking up on the last comments about training takes time, are there maybe 3 or 4 quick things that we could say to staff or point staff to try and prepare them for this and to build a little bit of resilience, so it's secure? I don't really want staff trauma.
I would say most important things are giving people, you know, the sense of a safe space where they can talk about that, so they're well supervised. There's a sense that there is a space for staff to share their anxieties. Mindfulness practice is really important. Give people access to basic stabilization techniques. Carol, do people all have access to the slides from your presentation? Because I think you made some really useful pragmatic steps in there around stabilization, about giving people ways of just feeling more grounded in their body, and that could just sort of breathing techniques. This is the 5, 4, 3, 2, 1 practice. Do you know about that? I think it's just simple, pragmatic ways of helping people feel, you know, more grounded, more in their body. But it's mostly around communication, good supervision, and compassionate leadership, I think, is really important as well.
Thank you.
Yeah, it's a shame that we don't. I mean, so in Sussex Partnership, we now have access to, you know, sort of staff wellbeing helplines and things like that. So I think it's really making sure that staff are aware of what's available for them, and that there's enough education for people to realise that this isn't normal. You know, that it's okay to expect people to be more resilient because they work in ITU, but none of this is normal anymore. It's, you know, and so it's okay if you don't feel okay. And people need to feel it's okay to ask for help.
Yes, absolutely right, Giles. And one of the things, if I may come in, it's because we are building this community with our colleagues right across the region. And although there's a lot of support, we knew in wave 1 and at the beginning of wave 2, there was something around communication and how you build those networks to strengthen as well. Because if you don't know where the support is or how to reach for it, you can have the best support in the world and people aren't going to take it up. And that's one of the things that we're doing here as a community of practice, because most of the people on the call are people who support people, either in the CCG or the provider organizations or arm's length body or internally in NHSI. So, you know, and you talked about leadership as well, and that's critical as well in this frame.